next invite Professor Richard Underwood. And again, Richard does not need any introduction. So Richard is going to give two separate talks, one after the other. One is on the basic understanding of viability, hibernation, and stunning. And also, I hope Richard will touch on the requirement for ischemia assessment in patients with ventricular dysfunction and obstructive coronary artery disease. And the second talk that Richard will follow on would be the role of nuclear techniques in the assessment of myocardial viability. So thank you, Richard.
Taran, thanks very much. I'm presuming you can hear me and see these slides.
Yes, we can. Thank you.
So thanks, Shazad and Charles, for the introduction. Highly relevant, of course. I think I'm having an enormous deja vu. I must be getting old, because I think that the all of at least the imaging data in this area is at least 20, if not 30 years old. And so you'll see that many of the studies that I'll show are from that era. But I recognize that we're still discussing this topic in MDMs, and that there is some confusion out there, particularly with regard to the distinction between viability and hibernation. So I was going to cover these 4 questions. What is viable myocardium? What is hibernating myocardium? How can they be detected? And I'm going to center with this really just on the radionuclide side of things, and leave Igor and Bobby to speak about echo and CMR respectively. And then a little bit more on the evidence for benefit of revascularization. So what is viable myocardium? Well, let me say, first of all, it's a bit of a grey area. I mean, a cell obviously can be alive or it can be dead. Actually, there may be some states in between where a cell undergoes changes or is in some ways crippled in terms of its ability to contract. So a cell even has a grayscale between being alive and death. Certainly the myocardium has a grayscale as well, because it can be made up of a mixture of cells that are alive or dead or somewhere in between. And so answering that question is not particularly simple. But I would say that the definition of viability is just that myocardium that is alive, with it bearing in mind my reservations that I've just said. I'm going to come back to hibernation. I'll say less about stunning, but let's speak a little bit about viability. Alive, meaning no more, no less than that. So if we think about the various different types of myocardium we might come across, these are all viable. Normal, obviously, normal myocardium that has ischemia, partial thickness infarction, some areas within that will be viable, maybe with ischemia superimposed on top, hibernating, stunned, even myopathic myocardium you might describe as viable. And I want to focus on this type of myocardium because even to imaging techniques, this might be very difficult to distinguish from hibernating myocardium. So I'll come back to that. But really what I'm trying to say is that hibernation is a subset of viability, and they are not interchangeable. Some of the, particularly American literature, uses the term viability as interchangeable with hibernating, but I would urge you not to do that. And of course, as I've already said, it's not a dichotomy, it's a continuum. I mean, we can have all sorts of mixtures of alive cells, increasing transmurality, perhaps starting subendocardial and then becoming transmural of scar, of dead cells. Or maybe the alive and dead cells are more intimately mixed up here. And so if we're going to detect viability, we really need a technique which is not just yes or no, but gives us hopefully some sort of distinction between these different shades of viability. Because it may be that if that is the situation, there is something that can recover, and if that is the situation, then it may not recover. Right, so enough about definitions for viability. Hibernation. As we've already heard, It's a subset of viable myocardium. It's first of all alive. It has reduced resting function, usually in the setting of chronic ischemic heart disease, but it has the potential to recover after revascularization. Now, Shabuddin Rahmatullah didn't actually invent the term hibernation. It was spoken about in earlier studies in the 1970s, but in the 1980s, he popularized it with this iconic patient who had an occluded LAD, end diastolic and end systolic contours from the invasive angiogram that look all the world for infarction. But after a patent graft to the LAD, you can see that LV function recovers. So this again is the phenomenon of hibernation recovering after revascularization. But of course, in a sense, that's no good to us because we want to know in advance of revascularization if something is going to recover. So we need some sort of alternative prospective definition as opposed to a retrospective definition. And I'd like to suggest to you, for reasons that ought to become clear, that this is a reasonable, at least imaging-based definition of hibernation, that it is myocardium that is viable, that does not contract, but is susceptible to ischemia. And I want to emphasize this third point because I've seen many people saying, well, that muscle is alive because my scan, whatever it might be, shows it's alive. It's not contracting, so it must be hibernating. And I just remind you that myopathic myocardium might look the same. So since hibernation is an ischemic syndrome, I will not ditch this aspect of the definition. Now, why is ischemia important? Well, it depends what the mechanism for hibernation is. And quite frankly, we're not dreadfully sure about that. There's various hypotheses. David Hurst actually dubbed it as a smart heart. If there's chronic reduction of resting perfusion, it rematches oxygen supply and demand by stopping to contract. Repetitive stunning, that is actually nowadays the favored mechanism. Of course, there might be a little bit of a mixture of the two, and I'll show you. Oh, somebody's speaking. I think we've got someone on speaker. Let me show you why repetitive stunning is a favored mechanism, and it dates from Paolo Camici and Norma Marino at the Hammersmith. With this study looking at using oxygen 15 PET to look at myocardial perfusion. Let's just look at the orange bars to viable myocardium alone, because oxygen is able to look at the distinction between perfusion to the viable myocytes alone or the fibrotic material. And these were patients who were undergoing revascularization, so they were defined as normally contracting segments, hibernating segments, or non-hibernating, based upon their recovery, post-operative recovery. And you can see that the resting myocardial perfusion, while drifting down, actually was not significantly different. So resting perfusion in hibernating myocardium is no different from perfusion in normally contracting segments. What is different, and this slide doesn't show it, is thought to be that the perfusion reserve is totally abolished. So as soon as myocardial oxygen demand increases, maybe a little bit of a tachycardia, because there is no reserve to service that the myocardium becomes ischemic, maybe becomes stunned, and stops contracting because of stunning. And maybe another episode of stunning comes along before it's fully recovered. And that is the concept of repetitive stunning, whereby there's frequent episodes of stunning that look for all the world like chronic reduced function. There's some other little pointers here as to what's going on in hibernating myocardium. These are studies from Belgium. Again, snipping out bits of muscle at the time of surgery, looking at normal myocytes here with a bit of a syncytium, areas that were proven retrospectively, by PET to be hibernating, or suggested by PET to be hibernating, I should add. With myocytes, maybe a little bit of an increase in interstitial fibrosis, some glycogen deposition, but on the whole, there are lots of cells, as opposed to scar tissue by PET, which is has very few cells. Going down a few orders of magnitude with electron microscopy, here's a normal myocyte, and two myocytes from areas of hibernation, where you see that the cell, the contractile apparatus becomes disjointed. Some of it's lost in the cell, and here it's abolished to around the periphery of the cell, with the center of the cell being empty, containing no contractile protein. So the theory got about that maybe hibernating myocardium stops contracting because it has lost its contractile protein. I have to say that I think a cell would be pretty clever to recover its contractile protein once it's got to this state. So I would doubt that as a mechanism for the failure of contraction. And I would also doubt it because here are some of our own studies led by Rafi Caprielian, looking at something different, and this is connexin 43 immunocytochemistry. So that's the protein that's involved in gap junctions on the end plates between the cells, and you see it around here in normal myocardium and in ischemic myocardium. These are snippets of muscle taken out during bypass surgery. And really only in hibernating myocardium did we see that the connexin 43 was totally disjointed. So it's only a hypothesis, it's yet to be proved, but it may be that the myocardium stops contracting because the gap junctions between cells become disarrayed and the cells stop talking to each other. Right, so summary on these mechanisms. I suggest to you that hibernating myocardium is viable, but akinetic, that it's an ischemic syndrome, it will improve in function after revascularization, and that the mechanism for it is initially repetitive stunning, which we would call functional hibernation, but that there may be later structural changes with loss of the contractile protein, which might make the whole process irreversible. So let's just go back. We'll come to that in a moment, but let's talk about how can they be detected. And I'm really only going to talk about nuclear imaging here because you'll hear more in a moment. Now, here's my cheeky slide, and my imaging friends and colleagues will forgive me for being cheeky, but there's obviously a number of things we want to look at in the myocardium with these patients, and there's a number of techniques that we have, and I put it to you that these are the sort of questions that can be answered by the different techniques. Now, before I get shot down in flames because I haven't drawn your favored line in this, perhaps I can put in some dotted lines for techniques or findings that are in theory possible but maybe are not universally applied. But you'll notice this is why I'm cheeky, because I've left only a single line going to viability from nuclear. Now, why have I done that? I'm not really being cheeky. I think I'm being genuine, because the difference between the nuclear technique and the other techniques is that we have tracers that are taken up by cells that are alive and not taken up by cells that are dead. So we have a positive signal for viable myocytes. The other techniques, echo is looking at function and deducing that there's viable muscle if function increases. And MRI is looking at the opposite of viability. It's looking at fibrosis from late gadolinium enhancement. It's not looking directly at viability. So what are the signs on radionuclide imaging of hibernation? Well, there's lots of things you can do with the radionuclide imaging, but of course, these three are the triad that I've already shown you that by the surrogate imaging definition would define hibernation. So what are those signals for viability? Well, with a nuclear technique, there's a number you can use. Thallium looks at membrane function, technetium looks at membrane or mitochondrial function. FDG looks at glucose metabolism. There's also fatty acid metabolism. And actually FDG by PET has, by some people, been said to be the gold standard for myocardial viability. I'm not a fan of that particular term, but there is no doubt that it is pretty good at telling you if there are cells that are alive. I won't cover this because I know that Igel and Bobby will. So here's an example from the PET literature. This is fluorodeoxyglucose, which we can do. This is actually ammonia resting perfusion, which we don't do, although we can now do rubidium for resting or stress perfusion. And the story goes that if you do have, in this area, for instance, glucose metabolism that is hypoperfused at rest, then that is the PET signature of hibernating myocardium. Now, I don't think it's quite as simple as that, because I've already told you these are resting perfusion images. I've already told you that Paolo Camici showed that resting perfusion is not necessarily reduced in hibernation. But I think when you do see this pattern with reduced resting perfusion, it is highly specific for muscle that is hibernating. Actually, PET is not necessarily the be-all and end-all of viability imaging. This is some studies that we did some time ago now, led by Mark Gunning, and we used tetraphosmin SPECT under nitrate cover in patients, and FDG PET, and this is gamma camera PET, poor man's PET, which we can't still do. But if you look at this patient with a big apical transmural scar, you can see that the signal for viability between the different imaging techniques is really identical. So we believe that SPECT, when properly applied, may be as good as PET for looking at viable myocardium. So here's a more modern standard myocardial perfusion scan. What are the signals we're seeing here? Well, concentrate on these two polar plots, the stress and the rest perfusion. If you're not familiar with those, this shows the whole, I love them because it shows the whole 3 dimensions of the myocardium in one single image. Apex is in the middle, base is around the outside, anterior wall, septum, inferior and lateral. This patient had had occlusion of an intermediate artery and there is no viable muscle there. It's a little bit bigger with stress, so there's peri-infarct ischemia. And in the infralateral territory, the circumflex disease, so the muscle is still viable, but it is hypoperfused with stress. So there is no hibernation here because actually, well, this is the polar plot of thickening. You can see that the perfusion defect matches the defect of thickening. So that is a match between viability and function. This is also a match between viability and function because it's fully viable and it is fully functional. So there is no hibernation here, but we're looking at viability and ischemia. Here's a slightly different patient. Concentrate maybe on these 3 bottom images, stress perfusion, rest perfusion, and the function. So this is an anterior wall that appears to be mainly, perhaps even fully viable. With stress, there's an inducible perfusion abnormality, so there's inducible ischemia. Does it do anything? No. So this is the triad of signs of hibernation. And in fact, the ejection fraction of 19% improved to 32% after revascularization in this patient. So by SPECT, simple common garden SPECT, we're answering all of those questions. Okay, what about the evidence for revascularization then? Well, again, old data, but this is quite interesting data. We looked at, this was dobutamine MRI for function, but this is the sort of stress echo or stress MRI way of looking for viability, and the gold standard was a recovery after revascularization. And so these techniques were specific but not very sensitive, whereas the nuclear technique we found initially to be highly sensitive but not very specific. So in that aspect, we were initially a bit disappointed, but I think we've learned a little bit more now, and it's to do with the time course of recovery. So our studies were imaged, I think, about 6 weeks after revascularization. Here are some echo studies from Leiden, again with pre-op assessment of function by echo, 3 months and 14 months, an area said to be stunned, hibernating, non-transmural or transmural scar. where the stunned myocardium improved in function immediately, and later hibernating myocardium improved a bit, but up to a year needed for further improvement, and scar, non-transmural or transmural scar, did not improve significantly. And the PET literature has similar findings. This was PET and actually snippets of myocardium taken out as well, showing similar things to what I've only shown you, but with the myocardium defined as stunned or hibernating, and the wall motion score improving a little bit at 11 days, but not much at all at 14 weeks with hibernating myocardium, significantly with stunned, but hibernating myocardium beginning to improve by 12 months. So the improvement in function is not necessarily an immediate thing, but it is something that I think should be taken seriously and not delayed, because there is evidence that the longer you leave myocardium repetitively stunned or maybe hibernating, then the less the chance of recovery. So here's from Jürgen von Dahl in Germany. He classified segments preoperatively as short-term hibernation, intermediate and long-term, with significant improvement in overall function for short-term, but much less in the way of improvement with intermediate. This is not quite fitting with what I just said, but looking at the percent fibrosis from the histology studies, there was a vague relationship between the amount of fibrosis and the days of hibernation before operation. So if you detect hibernation, it's something that you shouldn't and ah about, I don't think, because they may be losing myocardium all the time. But of course, in a sense, who cares about segmental recovery of function? Who cares even about ejection fraction? What patients care about is symptoms. And so it's important to look at symptoms and, of course, mortality. Again, from the PET data in Boston, the extent of PET mismatch for that, read hibernation, and the improvement in functional status after surgery, you can see that there is a relationship. Perhaps even more importantly, although less robustly in scientific terms, Jerome Bax put together a number of sort of meta-analysis, if you like, but there's a big mismatch of studies here in this meta-analysis. But looking at annual mortality of patients who had hibernation but were revascularized, left on medical therapy, or no hibernation. And you can see that the group who did best were those with hibernation who were revascularized, and those without hibernation were somewhere in between, without a lot of difference between surgery and medical therapy. So a little bit of a mishmash of a meta-analysis, but I think pointing in the direction of hibernating myocardium benefiting, or patients benefiting from surgery. So here's the STICH trial, much spoken about and of course much controversial, and you've already heard that there was a difference between revascularization and medical therapy in the 5-year and the 10-year follow-up, but no difference between those with and without viability. Actually there was, but when risk adjusted, it became non-significant. So the message got out that there's no point looking for viable myocardium in these patients with severe left ventricular dysfunction, because it makes no difference to their long-term outcome. I do not accept that message, and I'll tell you why I do not accept that message. And we can talk about the fact that the imaging was not randomized, and it was after the referral for imaging was after randomization. Here's the important thing: the majority of the viability assessment was, or 2/3 were by nuclear, 1/3 by echo, and the definition of viability was if there's at least 11 of 17 segments with uptake of tracer more than 50%, they were said to have viable muscle. Let me show you a typical patient. This is not from STICH, this is our own patient, stress and rest, and the patient has clearly had an inferior infarct and there's very little viable muscle in the inferior wall. Let's count the segments of non-viable muscle. 1, 2, 3, 4, maybe half and half. Let's call those two 5, let's call those two 6. So this patient, by STICH criteria, would be said to have viability. But what is there to benefit from revascularization? Actually, there's a tiny inducible perfusion abnormality in this apical anterior wall, but there's precious little to benefit from viability. So I would set aside entirely the deductions from the STICH trial to do with viability, because their definition was nothing to do with hibernation. Fortunately, there's other studies. Here's the PAR2 study, and it was a similar patient population to STICH, smaller study, but these patients were randomized to PET imaging or to standard care, and then the primary outcome measure was as you see. And perhaps disappointingly, initially, there was no difference between those who were randomized to PET and those who weren't. But in deeper analysis, it turned out that the patients were not necessarily managed in accordance with the findings of the PET scans. So when the subset of patients who were managed according to the findings of the PET scan were looked at, there was, admittedly, in a retrograde analysis, a retrospective analysis, there was a significant difference. But they went a little bit further and looked at only those centers who had ready access to PET, had expertise in PET, had integration between imaging, heart failure, and revascularization teams. And I suggest to you that Ottawa is very similar in that respect to Harefield and Brompton hospitals. And in these patients, there was a significant difference between the outcome for those who were imaged by PET to assess hibernation and those who were not. A little bit more from this particular study, looking at the extent of hibernation and the hazard ratio for medical treatment versus revascularization. And you can see the significant crossover is at about 7% mismatch size. So in other words, the extent or the amount of hibernation is relevant to the decision. And just as a little humorous aside, you can see, looking at cardiac death, if there is a significant amount of hibernation, and the patients were revascularized, and it turns out that they become immortal. But obviously that's just a statistical quirk. So finally, if you want to know a little bit more, I'd encourage you to stick this under your pillow at night to imbibe more information by osmosis. But it does contain this algorithm, if you like, where we suggested that if patients have left ventricular function and coronary disease is likely, if their main symptom is angina, then it's another algorithm. You know, you're revascularizing for angina. But if the main symptom is dyspnea, then first of all, look at function. And to me, it doesn't matter how you do that. You can do it by a number of techniques. If there's dysfunctional myocardium, look for viability. And again, I think you can do that by a number of techniques. And if there is viable muscle that is not contracting, look for perfusion reserve or inducible ischemia. I'd like to suggest that the nuclear technique has advantages over the other techniques, but no doubt we'll come to that in discussion, because if you do all of that, then you filter the patients or the myocardium down into the various different types, transmural scar, etc., and then you can decide on your appropriate management. So I'll leave you with that algorithm. In a summary, I would suggest that myocardial viability and hibernation are different concepts, but they're often confused. Viability is relevant when considering revascularization for ischemia, but hibernation is relevant when considering revascularization to improve LV function, and that hibernation is unlikely to be a stable state. I suggest that all three techniques can detect both viable and hibernating myocardium, and we're fortunate to have expertise in all three. We'll save the sparring match for my technique is better than yours for questions at the end. And I do believe that if you treat ischemia, if you find hibernation and treat the ischemia that's causing it, then patients can improve in their outcome.
Richard,